these are my potential conflicts of interest. So classification on the non-migraine headaches, and most of the headaches that we deal with are, can you hear me? Yeah, are with the non-migraine headache, but I would talk about the secondary headaches and mostly on the non-vascular intracranial disorder, high and low, and also to medication overuse. So these are my topics today, but we could take a whole congress about the secondary headaches because they are really interesting and we can learn so much. So as you know, that it is the leading cause of years lived with disability. We don't die from headache, but we live many, many years. And these are the global burden disease studies that we have. And that here in the green colors here, it is migraine and tension type headache that are affecting so many people all over the world are living with disability. And migraine, including medication overuse, is the second largest cause of years lost to disability, and in young females also number one. So there's a lot to do with medication overuse, and we really have to work on that because it's a secondary headache. So it's a migraine and a medication overuse. It's the tension type headache and a medication overuse. But again, the correct diagnosis, as I heard in cluster headache, is absolutely mandatory to give the right treatment. And we see many patients that have both migraine and cluster headache and are misdiagnosed, especially women. So it's extremely important. And so there are 8 most important questions. Do we have one or several? Take one by one and describe them. And that's where we see these that have both my normal migraines and my severe ones. And what are the severe ones? They often cluster headache as well. And it could be medication overuse. How long does it last? Very important question and easy to get. How frequent are they? Once a month or daily? What do you do? Again, do it like in a dark room, very quiet, and or you pace around. Then you have already the diagnosis of a cluster headache. What is the intensity? Where is the pain located? Are there any associated symptoms? And do you take medication? And yes, how much and how frequent? Extremely important. And here we have the most important questions. It's simple. We can teach our students to do it. We can teach our GPs to do it. And so with this instrument, it's not so difficult to diagnose headache disorders. So very important. And also the red flags are here. If you have a new type of headache, it's different from my migraine. You have to be alert. It could be a secondary headache. It could be a red flag for something more serious. So, and the question number 2, how long does it last? Is it seconds? Trigeminal neuralgia, CPH in minutes, cluster headache half an hour, or 2 hours, 3 hours, migraines, tension type headache if it's a chronic one. And if it is there all the time, it could be a medication overuse or chronic migraine or a combination of these things. So, and we also have to remember, if you sit in a very level 3 high specialist center and a very advanced, then you see the most severely affected patients. You see the most complicated patient. But if you sit in a private practice, see other kind of patient. Or if you sit in GPs, so it is the more tension type headache. It is more normal migraines and not the chronic ones. So there is a different distribution where you are, and you have to adjust your education, your interest. Where are you sitting? Because it's not necessarily reflecting all the headaches that you see. You see the most difficult one, the complicated ones, maybe with comorbidity. So the typical chronic headache patient, it is 2 to 8%. I know that you have a lot of medication overuse, much chronic headache in Moldova, more females than males. They come with a daily headache. they have fatigue, they have GI problems, they have poor sleep, they may even have fertility because that I will come back to that. They have anxiety and depression, and maybe also cognitive problems, and they are afraid of that. Of course, if you don't sleep, you feel tired, you feel exhausted, and you can't remember anything. Maybe you have a migraine-like headache sometimes, and then you have the normal background headache. It's a mix, and it makes it more complicated. But if you give them a diary, you can probably get a lot of information there, because most patients cannot describe it. I have it every day, doctor. It's there from morning to late night, and it's this and this. Sometimes it's bad, sometimes it's not that bad, but I have to take medication every day. So it's a mix, but you have to take it out. So we give them a simple calendar. It could be electronic, it could be a paper one. We use both because some patients prefer this and others. And you can see that they have 3 crosses, a migraine, a severe one. This is more a tension type headache, but very, very simple, that there's headache every day, different intensities, and the letters here indicate that they take triptans or paracetamol or drugs all every day. So simple. 1 month, 2 months, you can have it. It's a daily headache, no surprise. Daily intake of painkillers. It looks like there is a diet of tablets because they are desperate, and it's classified as a chronic migraine and a medication use. So you have a primary and you have a secondary. It's important also to have a treatment plan. So the characteristics are that you have the red ones, the normal migraines, but at some point it become more and more frequent, and it more and more intense, and you are never down to baseline. And there's frequency, severe intensity, long attacks. It could also be a tension type headache. It's not restricted to migraine. It could also be a post-traumatic headache that you take too much medication for. So the secondary headaches can also have a component of medication overuse. It's very important to even cluster headache can have it. So and a diary and a calendar gives so much information. There's a reduced effect of acute medication, and they take more and more. And they, of course, because they are depressed and anxiety, disability is poor and low quality because it's difficult to take care of the family and the job and everything. So they become depressed. So definition, simple analgesics, 15 days or more per month, not the number of analgesics that we had in old days. If it is triptans, opioids, or combination, it's only 10 days or more per month. So we have a simple saying that 2 days per week, it's enough to trigger a medication overuse. But it should have lasted for 3 months or more, not for 1 week, not for 1 month where you have surgery or something else. But headache patients are much more prone to this, and that's an interesting thing. So again, 1 to 2% prevalence vary across countries, and you have a higher one in Moldova. More women, high cost because they are desperate. These patients, they have it. Everything is there, and usually it's migraine or tension type headache that is there, but it can also be in other types of headaches. So I always have that in mind. If there's a progression, there's a more daily intake of medication. So it's a vicious circle. They have their migraine, they become more and more dependent on medication. They have relief, but it comes back, and it's only hours and hours, and then we are increasing the number of tablets. They always have tablets on them, in their bags, in the drawer, in the desk. They have medication everywhere. That's really a sign of this. So they take more. What is the mechanism behind that? Very interesting, because we don't see it in many other patients with pain disorders in the same way, or we haven't identified in patients with arthritis or arthrosis. that can take it, but patients that have an underlying headache, genetics or pathophysiology, they are much more prone to this, and it is a central sensitization. They have lowered pain threshold, lower concentration of the cannabinoids system, serotonin, and we can see that there's changes in the scannings. We can't do much with the genetics, but there is a genetic component, probably also a epigenetic component. We have seen that in recent studies, and the psychological mechanism, they are more dependent on their drugs. They are desperate if they don't have it. But interesting piece. So it has been discussed a lot whether it's substance related, or is it iatrogenic, because we prescribe more and more medication to a patient. So it's also a thing that we as doctors has to acknowledge, that we should be careful about these things. We see the whole complex mechanism of CGRP. I'm sure you have seen that as already. But if you take morphine and triptans, they upregulate your receptors, cyclic AMP. You have increased CGRP expression and release, and then you increase your migraines, and it become a chronic migraine. Even paracetamol can you see increase of spreading depression. And also the insights are giving something if you take it every day. And recently we have also documented that simple painkillers and simple NSAIDs, they can also affect your sex hormones. So females, they have more problems with getting pregnant, and males have lower testosterone. So there's also something there. It's not, there's no free ride here. So paracetamol and NSAIDs and opioids, they are drugs, and it's very important to acknowledge that. And in animal studies, these are, if you give a rat a triptan or paracetamol, and here's sumatriptan and naratriptan, for only 6 days, you can see there's an uprate. In the beginning, there is here, I can see whether you can see the mouse here, there is an increased threshold. That means a better pain sensitivity here, but after 6 days it goes the other way around. There's this hyperalgesia, that they are more sensitive. They don't get medication, but it takes up to 3 weeks before they're normal. And the same, oops, here we are, and it is the same with, if you copy that in opioids, in paracetamol, it takes so long time. And if you re-expose them to drug here, again after 21 days, they immediately switch back. And we can understand that because we can look at the trigeminal and see what upregulating here is, that the CGRP and substance P are upregulated already after 6 days, but it continued to be upregulated after 21 days. And it's exactly the same that we see in patients, that they are much more prone, as they have had medication overuse once, they can be prone to it again. So treatment, education, 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 also doctors' education, not only the patient, but okay. And whether we should do this preventive medication before, or is prevent withdrawal necessary? This is the treatment path that we wrote some years ago with Hans-Christoph Diener, that the education and counseling, very important, because many of them don't know that. They think they have to take painkillers, but they are not interested in prophylactics. They have to take it out for at least 2 weeks, 4 weeks. We say 8 weeks here. In Netherlands, they say 12 weeks. And give them prevention, and I'll come back to, and cognitive, that stress management and biofeedback. Those that are really severely affected with opioids, barbiturate, benzos, we usually consider inpatient treatment because they are difficult to work with. But prevention, that they do not come to overuse opioids or barbiturate. This is a study from Latin America and Europe, 5 countries in Europe. Here, como estas? And we see the frequency of headaches before medication overuse and withdrawal plus preventive. It was the old drugs, beta blockers, whatever we had at that time. And it was extremely useful just after 1 month. And very few of these preventives had the same effect. And it has also a significant effect on medication, pain intensity, cost, quality of life, depression, and anxiety. We didn't do anything for the depression, anxiety, but it was a function of the headache. And 78% reverted to episodic headache. And we don't see that with all the expensive antibodies or very expensive drugs that we have now to chronic migraine. So it is really cost effective, and it is very useful for the patient that they can come back to that, and it's also cost effective for the healthcare cost. You can see here it's either medication visits. A lot of investigations have been used in these patients before because they're chronic headache. They want scans and X-rays and all these things that are not necessary here. So you can treat their medication overuse. You can also reduce the cost. So it's cost effective. So should we take the medication completely or after? We did that study that it was restricted and that, and took a so-called cold turkey without any medication in 2 months, except for little sedatives in the first day and antiemetics. It was allowed. But it was more effective with complete than reduced intake. Very important. And also we asked them after 12 months, was it difficult to do a complete withdrawal, or was it not so difficult? It was. And to our surprise, we saw that those blue with a complete withdrawal, they found it much more easy than those that had restricted 2 days a week. Because they always had to argue whether they should take it today or tomorrow or save them to the next day. So I always compare it with quit smoking, and it's also difficult to do two cigarettes a day instead of 20 cigarettes a day. Better to stop completely, but it's easy to say. It's not so easy always to do. So complete withdrawal. We also about the preventive medication, we discussed that, and whether it was complete withdrawal, a Danish model here in 2 months, prevention alone here in the orange dots, or withdrawal plus prevention. And we saw that it was more effective with withdrawal plus preventive at the same time, and it was the highest chance to be episodic and also faster than it was, but and we followed them for 12 months and saw that as well. So it was so now our strategy is to withdraw them completely from the beginning and put them on preventives. So because it was in favor of that quality of life and dependent score as well. So, but it is always a discussion with the patient. Where are they? And but we as doctors has to think about it. So, existing strategies here is education and education, primary prevention, extremely important. We had an awareness campaign to general population, and the sooner the better, because it's really important to give this awareness that drugs are drugs and they should not be taken every day. Withdrawal and then preventives. And it's indicate a proper use of healthcare resources, proper use of the acute triptans, and education and withdrawal are effective. And start migraine. It could be beta blocker, candesatan, calcium blocker, what you have in your armamentarium, not necessarily the expensive ones, because they haven't had a head-to-head comparison by now, but beta blockers, they're simple and easy to use as well. So Then I'll say a few words about the high pressure headaches. They are rare. They were rare in old days, but with increasing obesity that we see idiopathic intracranial hypertension, we see more and more, and we have about 400 in our clinic now with high intracranial pressure, more females than males, and they have the headache, a different headache. It may look like a migraine, look like a tension type, but it doesn't respond to anything. They have papilledema and they are risk of losing their vision. They have pulsating tinnitus, push, 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 like that. You have to ask them because they don't say it. They are obese, you can see that, and they have a high pressure, ICP. They have also these emotional symptoms as other chronic headache patients, but they have also clear cognitive symptoms. The concentration, memory, they are slow. They're slow cerebrated. They are encephalopathic. They come late and say, "Why are you coming so late? You are losing your vision, my dear girl." But they think it's just a headache, but it's not just a headache. So they have blurred vision. They may have visual loss, but it comes gradually over time. And if you don't look for it, you don't see the papilledema. And the patient we have lost patients with this vision, and they're completely blind now. It's irreversible. So they are obese, you can see that. And you have the headache, that's different. And we work on mechanisms. So it's closely related to obesity. And as you know, as neurologists, that there is this balance between production and drainage of CSF. We know very little actually about this, also in normal conditions. We know that we have high ICP, the high pressure things, and it's the same here. It's not a tumor. In old days, we called it soda tumor, but it is, we don't know exactly what is going on here. And the criteria are based on expert opinions, papilledema, normal exam, normal imaging, normal CSF, and high pressure. But there is a gray zone here about this, because some of them are in here in between, and in obese individuals, it can be difficult to be relaxed. So we up to 40% of our patients have a wrong diagnosis. They are overdiagnosed and few are underdiagnosed. So it is a difficult diagnosis to give and extremely important. A simple thing, how do you position your patient during a lumbar puncture? Because if you have bent knees and bent neck, then you can increase your pressure with up to 10 centimeter. So it's extremely important that they're extended, they are relaxed as much as you can with a needle in your back. But it is extremely important because you can modify the pressure so much, and then you come to wrong decision and wrong diagnosis. We try to work on non-invasive ICP measurements. We do, because it's a snapshot with an LP. And I don't know whether you do it. Many countries, it's the anesthesiologists that do the lumbar puncture. Here we do it ourselves. The MRIs are not specific. Many have empty cellar or party empty cellar because you are young and you are obese. So it's not a diagnostic criteria in itself. We do ultrasound of the optic nerve and compared to the lumbar puncture. And there is a very close correlation to the optic nerve sheet diameter here. You can see it here. And you can see the optic disc elevation. If you're not good at the direct ophthalmoscopy, it can be difficult, but you can visualize it here. And it is very closely related to the opening pressure of the ICP. And it's atraumatic. It takes 10 minutes and fairly easy to learn. And you are probably familiar with ultrasound. So here you have the patient before. They have the diameter of 0.7, but after the lumbar puncture, just half an hour, it's reduced with 14%, very dynamic, whereas the optic disc elevation is more stable. And here we have a normal person that also have lumbar puncture, and you can see it's much smaller. So an easy way to do it, and you can do it again and again. The headache is very difficult to manage. It doesn't respond to the usually triptans and usual drugs. It looks like like other ICP headaches and chronic migraine like. They have also medication overuse, and it's still present after the pressure is normalized after 1 year in half a patient. So it's a trigger. What is the mechanism? Topiramate can be used, but again, you know, topiramate has all the cognitive side effects, and these patients are cognitively impaired in already. So another thing that we work on is the common link between obesity, migraine, and IIH, systemic inflammation, CGRP release, and increase CSD, photophobia, and these animals. So we needed an animal model, and we have developed that with fat rats, diet-induced rats, and we can monitor the intracranial pressure for up to 50 days, 2 months. And yes, they are higher ICP all the time. Here, the red dots, and it is closely related to the abdominal fat. So it's the abdominal fat that is the trigger here. It's not the BMI in itself. And they have also a lower threshold, so they are more pain sensitive. So it could be a trigger for both migraine and IIH and other headache types with the obesity. And we can also see that they have papilledema, these rats, and they have atrophy of the optic nerve, you see here. So it is also closely related to the ICP. So, and we look at trigeminal ganglion, we can see the gene expression, that they have also increased expression of CDRP and TRP1. So it is interesting. It's a new model for brain water production and regulation, but it could also be a model for drug testing and chronic migraine. So it's an exciting field. And we also have to look to the what is going on in the general physiology about brain water. I have learned that the CSF come out of the villi acnoidalis in the sagittal sinus, but that's probably not correct. So it could only be in the pathological stages, whereas the physiological, less than half of the CSF, the half liter that we produce every day, goes that way. It runs out through the nose, it runs out to the other cranial nerves, it runs out here to the basal foramina. So there are perineural spaces that are perivascular spaces that it goes out in. So very, very interesting. Also with the glymphatic system that has been described, they are running. So it's much more in general physiology that we don't know. And can we understand that, we may also understand some of the headaches. So here is from Norwegian group that have scanned with a tracer IIH patient versus reference group and compared them. You see the tracer is very restricted outflow of it, whereas in reference group in more healthy subjects that you get rid of the tracer very quickly, but they don't do it in IIH. The glymphatic system is impaired in IIH, and they can quantify it in different areas. It's the fourth ventricle, lateral ventricle, and third, and it makes sense, but it's a difficult study to do. And lastly, but not least, the low pressure headaches. They are very interesting, and there's new things going on there as well. They have also chronic headache. They have low ICP. They have tinnitus and impaired hearing, and they can even come with cognitive impairment and dementia. And they have an orthostatic headache. You know it from post-lumbar puncture headaches. As soon as they come up, they have a severe headache and vomit, and when they lie down, they are okay. But it looks like a new daily persistent headache after some months, after some years, and very difficult to. So every patient that you have with a chronic headache, chronic daily headache, or new daily persistent headache, ask them, how did it start? How did it start? Did it start from one day to another? Then you have to be go into this history, even years after. You know it from the, if they have a spinal anesthesia, they have a spinal tap or something like that, a low pressure. Don't use this to measure that, because it's usually normal, and we have to work on these criteria because they're not good, and you give them another trauma with a new LP. But it has developed in temporal relation to this, so it's sudden onset, usually sudden onset, and that's very important to work on. And look at the brain imaging with gadolinium. They have sagging or Pachymenon enhancement. Then you look for a defect in dura. These are signs and symptoms from a large study from London. Orthostatic headache is the key element here, the key sign, and then a lot of very different one, even cognitive symptoms here. I had a patient that was diagnosed with frontotemporal dementia, and she turned up to have this orthostatic headache, a spontaneous. We identify a leak, and she is healthy now. So but she presented with a dementia. So it's really, really tricky one, but wonderful to work with because you can cure them. They present with a headache, but miming chronic migraine, a new daily persistent over time. In their study, it was from 1 day to 20 years. Again, history. And leaks are different described. Be a spur, a bone spore. It could be a diverticulum. It could be a fistula, and it could be unknown. And we have a series now of 60 patients, and we see more and more fistula here, but it's tricky to work with. And again, look, when you do lumbar puncture, use the atraumatic needle because they have much less post-dural puncture. But even after post-dural puncture, it works to give them a blood patch in the lumbar region, and that's what we do. And if it doesn't work with blood patch, non-targeted, we go for try to identify the spur where it is, and the surgery or blood patch, targeted blood patch. But it's complicated, it's time demanding, and need a specialist. So the take-home message: have many phases, coexist, exciting mechanisms. The secondary can be challenging, extremely important to identify them. It's a symptom of something else. And they can have more than one. They can have migraine and a secondary one, and it's important to find them. So we run the master's program in University of Copenhagen, and it's very exciting. And we have students from all over the world. It's really exciting to run, and it's so rewarding to have headache specialists. So I invite you from Eastern Europe as well, from Moldova, and you're more than welcome. We had many good, excellent students that has graduated, and we start a new group again. So thank you so much.